Hi, my name is Erica Sanborn, and welcome to my talk, How Medical Technology Contributes to Racial Inequality in Healthcare, a Biomedical Analysis. This first part of my talk is based on the work of Keisha Chantel Ray, and I will briefly consider a Black bioethical lens using the principlist framework laid out by Beecham and Childers, by first thinking about the broader context of racial inequality in healthcare through the four core ethical principles of autonomy, beneficence, non-maleficence, and justice. I think this preliminary setup is necessary because the ethical issue presented later in this talk is situated in this context. We typically think of autonomy as being about a person's right to freely choose and refuse treatments after being presented all available options, right? To think, decide, and act with independence. That's autonomy in a nutshell. And the typical constraints on that freedom would be things like coercion, intimidation, or not explaining all options, because for autonomy, patients must be free to come to their own conclusions and make free decisions. So if we extend our understanding of autonomy just a bit, I think we can readily see that there are unique additional obstructions to freedom and autonomy that Black patients experience because of systemic racism. When Black patients question a treatment plan, they risk being perceived as the so-called angry Black person. And avoiding that perception for some Black patients is seen as necessary for their survival. So, keeping their head down, not upsetting anyone, this can be a choice for some Black patients as a means of survival within systems that are not designed with their safety and well-being in mind. A Black patient may feel the need to not really question treatments that are offered and to choose to engage in some Black respectability behaviors so as to not upset the provider of their care. This means Black patients are not necessarily making free and autonomous decisions in a racist healthcare system, just because they may have nodded in agreement and said they had no questions. I'm obviously not able to speak for any Black person, and I'm not describing the behaviors or limitations of any or all Black people. Individual patients have varying degrees of that freedom, but I am describing the lens of Black bioethics as it is, which compels all of us to be aware that systemic racism is an affront to autonomy. Beneficence, as a principle, means the provider or researcher must do what they feel is best for the patient. Deciding what constitutes the best thing or doing good is at the discretion of the provider, which means that their determination of what constitutes doing good can differ from what the patient might think is best. Whenever the provider makes a decision that is what they think is in the patient's best interest, if that goes against the patient's judgment, that's known as paternalism. And in a fundamentally racist healthcare system, beneficence and paternalism are going to go together quite a bit. And what even constitutes good varies by cultural context. Non-maleficence is the principle of avoiding the cause of unnecessary harm. And that involves the provider weighing risks and benefits of an intervention or treatment. When providers rely on algorithms that are racially biased and trend towards undertreating the conditions of Black patients, they have violated the principle of non-maleficence, as has the entire healthcare system, for accepting the use of such biased technology that privileges certain categories of people while disadvantaging certain others. For example, despite the known racial disparities in preemptive kidney transplants, in 2019, Black patients made up 31% of the waiting list for a deceased donor kidney, while white patients made up 38% of the wait list. And yet white patients received 65% of those preemptive kidney transplants, while Black patients received only 17% of them. And this happens on top of the disparity that Black patients are already 2 to 4 times as likely to have chronic renal failure to begin with. This level of deadly inequality reflects both maleficence and, moving on to our last principle, a lack of justice. Racism is a determinant of health, an injustice that has been well documented. Using a Black bioethics lens, consistently unequal physical and mental health outcomes by race represent racial injustice. We should not be able to statistically predict survival rates by race, but we always can, because racism is embedded in healthcare. Justice in bioethics often has to do with resource allocation, and an additional consideration for justice is that Black patients should be prioritized across the board because they have been disadvantaged across the board, if justice matters. An example of this form of injustice pertaining to resource allocation is the non-prioritization of the Black population during the COVID-19 vaccination rollout of early 2021. After the frontline healthcare workers received vaccinations, an age-based vaccine schedule was employed, starting with all people over the age of 75. And that might sound fair from a distance, because everyone over the age of 75 could, in theory, be vaccinated. That sounds colorblind, which is what people think is fair. It's also true that COVID-19 mortality rates increase with age. However, the vaccination clinics were disproportionately located in the suburbs and other places where older, white, and more affluent residents usually seek care. Also, an age cutoff of 75 is at the average life expectancy of Black Americans in 2021. Basically, the Black population is younger than the white population overall. They are more likely to be infected with COVID at a younger age, and then they are at greater risk of dying from the disease once infected. These are facts. Alas, since the prioritized vaccinations went to the affluent, white, older population in the suburbs, they did not go to those in the greatest numbers of those at greatest risk of death. Nor did early vaccines go to those already additionally burdened by systemic cumulative injustices of the kind that shorten one's life expectancy to begin with. Since Black citizens in particular have already experienced higher rates of COVID-19 infection, greater likelihood of serious disease once infected, followed by higher mortality, adding to that cumulative disadvantage by effectively pushing the same people back in line from receiving the vaccine is gravely unjust. This demonstrates a key drawback of the so-called colorblind approaches to injustice, that they benefit those who are already privileged at the expense of those who are already disadvantaged, all while appearing to be neutral. And the problem is in not correctly identifying cases as dissimilar. As of April 19th, 2021, with race of the patient known in just over half of all vaccinations to date, about 35% of white people have received a first dose of vaccine, which is significantly higher than the 22% first dose vaccination rate for Latino or Black people. If we distributed vaccines according to need, those with more needs would have received prioritized resources according to the justice principle of equality. But for that to work, we'd need to correctly identify dissimilar cases as dissimilar and distribute equally based on need. In other words, by ignoring the realities of racial inequality, the ethical principle of justice is continuously violated. The ethical issue at the center of this analysis is the continued use of technology that exacerbates racial inequalities in healthcare outcomes. In this talk, I will outline 3 cases of racially biased technology in healthcare: pulse oximetry, eGFR scores, which are used in diagnosing and planning treatment for kidney disease, and SOFA scores, which are triage scores used for things like ventilator allocation during public health crisis situations. As I describe each of these 3 issues, I invite you especially to think of those 4 ethical principles, especially how they are violated and what makes something unacceptable from an ethical standpoint. Dr. Michael Soding and his colleagues found that pulse oximeters underreported hypoxemia approximately 3 times as often in Black patients as in white patients. Hypoxemia is low oxygen. The machines typically reported that oxygen levels were within normal limits, when in reality, oxygen levels were lower, as confirmed by arterial blood gas measures. And this is a big problem because if the true lower oxygen levels were known, that would lead to different treatment decisions, timelier crisis interventions, and other early intervention types of decisions that are based on the information gleaned from pulse oximetry. Since pulse oximeters underreport hypoxemia systematically in Black patients, this may very well help explain why Black patients with COVID-19 arrive at the hospital sicker, are admitted at much higher rates, and have significantly higher mortality rates. I'm going to show you. So I have a pulse oximeter here, and I'm going to measure my oxygen with this machine. And then, so never mind my tachycardia. I have a cardiac issue that we don't need to discuss, but my pulse ox is 97%. Okay, now you see it on the top, 95, 96, 97, jump in between 95 and 98, it looks like, right? So that's good. And anything above 90 is considered fine, and anything below 90 is cause for concern in healthcare in a triage setting. So I'm between 95 and 98. But as you can see, I'm also light-skinned. If I were Black, that could be as much as 8 to 10 points higher than the actual oxygenation level in my blood. So since my pulse ox was read between, 95 and 98%, right? 95 to 98%. subtract 8% from that, I could be in the 87% to 90% range in reality if I were Black. All right? So if my oxygen were in the high 80s, that's not a dire situation, but it is a warning. It means that's not okay. That's not quite enough oxygen. Something's wrong. But this thing won't show it. If you have that differential of 8 to 10 points, it's not going to show it until you're already in the low 80s or 70s. Then it's going to reflect that you're in the 80s. You know what I mean? Which is why someone has to be, if they have a dark complexion, they have to be really sick for the pulse ox to show it, because there's that inflated value that's reported. So my pulse ox is 95 to 98%. I can trust that. Black patients should not, because several studies have found that hypoxemia or low oxygen is underreported in Black patients. So that's a thing. And it's important to note that this racial bias in pulse oximetry is not a new observation. The publications going back to 1990 document this shortcoming of the technology. And as of the time this talk is being given, there has been no instrument replacement, no recalibration effort, or other intervention to address this known issue of racially biased pulse oximeters in use across the US. The glomerular filtration rate, which I will refer to as the GFR from now on, is a score that's used in the clinical setting to determine how a patient with kidney disease is going to be treated, what dosage of medication is appropriate, suitability for placement on the wait list for kidney donation, things like that. And this one score, the GFR, has significant importance for the survivability of chronic kidney disease because treatment decisions are based on this score. That said, it's not regularly measured, but instead it is estimated using an algorithm. And the estimated GFR algorithm includes an indicator variable for race. And when that patient's race is coded as Black, the eGFR score underreports the severity of their chronic kidney disease. Like with the pulse ox, the eGFR suggests that things are fine when they aren't. If a patient's condition is declining, the eGFR will show that things are fine longer until they're really bad, and then it'll show as bad. This leads to Black patients not having early access to dialysis since their eGFR score underestimates their need for dialysis intervention. It also means Black patients, when they do initiate dialysis, they are generally sicker, which leads to shortened lifespans and less successful treatment. The racially biased algorithm for GFR disadvantages Black patients when it comes to kidney transplants as well. So, Black patients are 2 to 4 times more likely to progress to severe kidney disease, less likely to receive the best treatment for it, including transplantation. And as of the time of the current talk, the racially biased GFR algorithm is still in use across the US. The sequential organ failure assessment, which I will refer to as a SOFA score from now on, that's a score from an algorithm that predicts the likelihood of a patient dying in the short term. And when is this used? This is used during a crisis like the COVID-19 pandemic, when life-saving medical equipment like ventilators may be in inadequate supply, and a utilitarian approach to distributive justice takes over the healthcare system at large, seeking to do the greatest good for the greatest number of patients, and therefore decisions about things like which patient gets a ventilator when there's not enough ventilators to meet patient needs are based on things like SOFA scores, because if a patient's likely to die anyway, a ventilator is determined to be better used for another patient who's less likely to die. But so what if Black patients are on average more likely to die in the hospital? If we are basing our resource allocation decisions on a score that captures this level of inequality, we only advance that inequality by allocating resources away from the patients who are already disadvantaged within the healthcare system. So far, I've discussed a lens of Black bioethics, and I've run through the overall ethical issue that technology is racially biased yet still in use in healthcare systems today. And I've described 3 examples of that racially biased technology: the pulse oximeters, the GFR scores, and the SOFA. I think the cause of the issue, as framed, is that testing is done on samples of presumably predominantly white participants. In other words, the common cause of this ethical problem is faulty research methodology. All of us in research know that our samples need to represent the populations of our interest. And by drawing samples that lack statistical power for racial groups other than white participants, researchers have repeatedly declared that their intention is to produce medical technology and algorithms designed to keep white people healthy. One common proposed solution is to adjust the technology, to try to numerically accommodate Black patients within the existing technologies. This has been attempted with SOFA scores, with a sort of health equity factor, and could potentially be attempted with pulse oximetry. Removing race from the eGFR algorithm is a similar response to the problem. And this would be a sort of redistributive justice, in that we would not be correcting the underlying injustice, but amending it. And to this proposed solution, I say no. Research must include Black participants. It must be community-oriented. It must have stratified, representative samples. Researchers need to stop pretending they were absent the day they taught basic research methods, because methodology to date leads to horrible outcomes, systematically, for Black patients. So what other solutions are there? I could keep outlining them, but I invite you to do so in light of the principles of bioethics with respect to a Black bioethical lens. And no matter what the short-term fix may be proposed for adjusting use of existing biased technology, any such post hoc adjustments would introduce a new problem. Providers would inevitably have to sort patients by race in order to say which people get the adjusted treatment or test, right? And that process should sound as horrible as it is. And it should call up a vision of some kind of separate but equal hospital ward and other segregated settings, which could result anew here, and all of which would create psychological harm for patients to endure, violating maleficence in a new way. Plus, how would a patient's race be assessed and recorded anyway? Would we rely on self-report? There are people who claim an identity of a certain race, and their complexion does not lead you to that you wouldn't sort them into the same race. And with pulse oximetry, it's a matter of darkness of complexion that is what influences the readout. So imagine the following person, whom I will describe, okay? And think about how we're going to sort him in our hypothetical situation where we have to sort people into a modified algorithm for pulse oximetry or something. All right, so he is half Asian, okay? His mom is a mix of Thai and Chinese. He is 25% Caucasian, 1/8 Black, and 1/8 Native. So what race should the provider assign that person? I mean, maybe you're going to call him Asian, right? Because he's half Asian. Or does he get the Black adjustments or does he get the white unadjusted treatments?
Can we get this straight? What do you call yourself? Do you call yourself African American? I know you are. Your father's half Black, quarter Chinese, quarter American Indian, mother's half Thai, quarter Chinese, and quarter white. So that's why you are America's son.
Yeah.
You are America's son.
A little funny thing is, growing up, I came up with this name. I'm a Combination.
A Combination.
Caucasian, blue, Black, Indian, Asian. Combination.
That's what you call yourself?
Yeah.
Yeah. Okay, he does not say he calls himself that now. He said that he called himself that as a child. He was little. Here's what he did say, because I realized he was getting himself in a lot of trouble, so I went back and asked him the question again. I realized he was in more trouble than he knew when he said it. I asked him about how he sees himself now, and this is what he said.
What matters
when you're
is,
called one or the other, does it bother you to be called African American?
Yeah, it does, because to be honest with you, if I would have to label myself as anything, ethnic-wise, I always had to check a box, in those little forms and stuff. And they said pick one. I can't. I usually pick African American, Asian, because those are the two households I was raised under.
And I just used that example to show you that it would not be a simple process, and it would undoubtedly cause harm. What else? What else could we do? We can't just remove race from the estimated GFR algorithm either. More a priori research needs to be done the right way with representative samples, because studies have already found that simply removing the race indicator from the existing GFR algorithm creates a new and differently serious problem, in that it then overestimates the problem of reduced kidney function, to the point that then Black patients would be treated with dialysis or even transplant when it's not necessary. So that's not a good fix. And the problem with the SOFA scores, that's one of conflicting priorities, because to serve the greatest good for the greatest number, that's a goal that's in conflict with health equity principles and distributive justice. Healthcare systems need to monitor outcomes for equity so that they will see when they are increasing disparities. When they realize they are a part of the problem by increasing disparities, systems should be obligated to compensate for the additional injustice to which they have contributed. Other options. How about they discard the algorithms and just go with human decision makers? I think we already know that humans tend to be pretty biased, so that's not likely an improvement. There must be an intentional redistribution of resources to compensate for cumulative disadvantage based on population health data that indicate racial disparities in comorbidities and outcomes. So my proposed solution is that we must change the way we do things. Research must include Black patients in the samples so that treatments, technologies, and algorithms are designed for them, lest all IRB approvals, patents, and FDA sign-offs be withheld. Nobody gets to design treatments and technologies for white people only anymore. The increased mortality of Black patients is wholly unacceptable. And the fact that I even have to present this as a case is nauseating. I am moved by the sentiments of population health researcher Elizabeth Wrigley Field, who points out that in 2020, when excess white deaths for once approached a fraction of the excess Black deaths caused by racism every single year, look at the depths of economic and other resources we were able to find in order to protect the lives of our neighbors during the COVID-19 pandemic. The truth is that racism causes a pandemic's worth of deaths every year. The fact that we continue to let it happen shows that we just do not care. Bioethics does not have a principle about race, perhaps leading some ethicists to conclude that ethical decision-making should indeed be colorblind. But the SOFA scores and their recent application to triaging ventilator allocation during the pandemic highlight how bioethics can go wrong when colorblind ideals are upheld. A patient's SOFA score comes out of a model that is dismissing the effects of race on health. SOFA does not include any variables that capture the adverse impact on health of being Black. To be clear, there is no genetic cause of bad health outcomes of being Black. This is all racism. This is all social ill. If one assumes that patients enter the world of clinical care equal, we ignore the differential impact of social and structural determinants of health, income, education, and racism. To make ethical decisions, we need to see and consider those determinants of health. Sociologist and race scholar Eduardo Bonilla Silva has published a lot on the topic of systemic racism. And in his more recent writings, he emphasizes that systemic problems require systemic solutions. The problem is not the racists, in other words, not the Confederate flag-waving white supremacists, but the reality is that all members of the dominant race continue to go about their lives within a social order that is stratified by race, privileging some while disadvantaging others. The fact that we all exist within a racialized social order is everything, and it makes solutions necessarily systemic as well. I want to read a brief quote from Bonilla Silva because it really frames my response to the three-part issue I outlined in this talk. This is Bonilla Silva. What is needed is a concerted effort to eliminate the racial practices and culture that reproduce white advantage and non-white disadvantage at all levels. This way, reforms to the police or our healthcare system will not be weakened by the other existing elements of the racial order. Ultimately, addressing systemic racism is like playing whack-a-mole, except that to win the game, the player should try to simultaneously seal all the holes from which the mole can come through. In other words, bioethical decision-making needs to have a wider lens than the narrow scope suggested by colorblind framing. Ignoring race means ignoring racism, leading to decisions that result in furthering the racial inequality that is already much too grave in healthcare outcomes. As ethics begins with gathering the facts, race and racism are essential facts in the story. It is often cited that highly educated, affluent Black mothers have a higher risk of death in childbirth than high school dropout, low-income white mothers, which suggests that race is a main effect predictor of maternal mortality, even when controlling for all the other social determinants of health. And telling that Black mom to be that you don't see color does not improve her survival chances. The bioethics issue at focus in this paper is that of racially biased technology in healthcare. And yet fixing those three items is to engage in a game of whack-a-mole unless broader changes were to happen to address the systemic racism that is pervasive not only within healthcare systems, but in U.S. society at large. The ethical principle of beneficence includes an obligation to not only do no harm, but to remove sources of harm as well. And in that beneficent spirit, all of us are obligated to recognize that we function within a racialized social order, just as patients do, and to dismantle these oppressive forces that cause such injustice. And I think we need to do nothing less. Thank you for listening. I welcome your comments and questions.